Okay, now we're going to jump into OIs. We're very pleased to have Dr. Henry Masur from George Washington University. He also has other roles at the National Institutes of Health. He was heavily involved in the treatment of opportunistic infections at the very beginning of the HIV epidemic, initially at Cornell and then at NIH. He set a lot of the standards that we use now for the treatment of most OIs, and especially for staging risk associated with CD4 counts back in the early days. He's remained very active in treatment and of OIs, their modalities, how things have changed, prophylaxis, and he's going to lead us through a review of the more common OIs that a lot of you who are like me and have gray hair saw this firsthand, but a lot of you who are new to the field maybe haven't seen as many or maybe even some of these opportunistic infections, and so the purpose of this panel is to review those and have a discussion. Please feel free to come to microphones during the presentation, and we'll incorporate your comments as we go. So panel and Dr. Masur.
Thanks, Mike. Since Mike is up here, we're going to ask him most of the questions. It is fascinating to see how much progress we've made over the last 45 years. And obviously, a lot of the progress is because the group here takes this information and uses it to the benefit of their patients every day. But it's interesting, in the year when Mike and I started, all we saw really was opportunistic infections. And when I actually came to the National Institutes of Health in the early 1980s, they weren't quite sure what to do with the AIDS program, so they put it in critical care medicine because almost all the patients were in the ICU when they first got there. And obviously, we've come a long way since. Looking out at this audience, there are probably some people who practice exclusively in the outpatient clinic where they don't have extensive resources. So some of the cases we're going to talk about are, what do you do empirically when you see someone with mild, moderate, or severe disease? How do you decide whether it's an opportunistic infection or something else? And then we'll talk about some of the hospital-based issues that we should all be aware of. But let's just start by reminding everybody who's on the panel. And we'll start with Mike Sag, and you only get 10 seconds to say who you are.
I'm Mike Sag.
That's all you need to know. All right, going from right to left.
I'm still Trip Gulick from Cornell in New York City.
I'm Jennifer Janelle from the University of Florida in Gainesville.
Roger Bedimo, VA North Texas and UT Southwestern, Dallas.
Sandy Springer, Yale School of Medicine, Infectious Disease and Addiction Medicine.
Hyman Scott from San Francisco, UCSF.
Great. And actually, Roger has offered to answer all the questions, so we may start with him.
Yay.
So let's start. I have no financial conflicts. You've heard about their financial conflicts. And what we'd like to do is have the learners identify why opportunistic infections still exist, although that's one point which I think is probably obvious to all of you. We're going to talk about inpatient and outpatient approaches to infections, and then we're going to talk about IRIS, because a lot of the questions that came before the session have to do with how to deal with IRIS, so we'll spend some time on that. I think everybody in this room understands why opportunistic infections still occur in this era. We have great tests, we have great drugs, but we don't have complete implementation, and that's what a lot of this group is focusing on. And it was really very gratifying to see what Heather Houck presented at the beginning of this, how well we're doing now. But while some of my data may not be up to date, and if Clover Barnes is still here, she'll probably get up and tell me my data on DC is not current, but probably in all of your jurisdictions, your data look a little bit like what we have here in DC, and that is that if you look at the cascade of care, not all patients are either identified with HIV or are suppressed, and those are the patients, obviously, that are going to develop opportunistic infections. But this group here in Orion White Clinic clearly is doing much better than the city as a whole, and one would wish that everybody could get the kind of care that you delivered in your funded care, in your funded clinics. So it's really the 13% of patients or the 11% of patients who are not either under care or not identified that are the ones getting opportunistic infections. It's interesting to see what are the most common opportunistic infections in this era. These are not reportable diseases, so it's not easy to get data. But I think in the data I'll show you in a moment, what we might call the cardinal opportunistic infections that we saw in the 1980s are still probably the ones that are most often seen and most often on your mind. That would be pneumocystis, cryptococcus, toxoplasma, and less so CMV retinitis, disseminated mycobacterium, cryptosporidia. Those are not as common for reasons that we may or may not discuss later. But why do I think these are the most common? We've worked for over 30 years on the guidelines for opportunistic infections, and if anybody has any comments on either the content or the format, we're interested in how we can improve these. But we're very gratified that in this administration, they are committed to still continuing the guidelines, so we're very pleased with that. If you look at how people use the guidelines, this presumably is some indication of how often you're concerned about or you see these diseases. And if you go from left to right here on the slide, pneumocystis, cryptococcus, toxoplasma, MAC are the most commonly accessed sites. So I think these are still common. And I wish I had better data, but I think this means that these diseases are common. I might just say in terms of the guidelines, we try to update these guidelines in real time, so we don't just update them every 5 years or every 1 year. When there's something new, we try to update that within the next few months, so that some of these things that are not as often accessed are still updated. And you may not want to look up Tallaromyces or Chagas disease or malaria, but when you get a patient, these guidelines are a good start for what to do, because those are the ones I suspect none of us really know what to do unless we suddenly look up the guidelines. So we try to keep that updated as well. One of the things that Christine brought up that we might talk about later are CD4 counts, and they're a little bit different in HIV and in the transplant population. So one of the questions is, we all know these diagrams about what CD4 counts indicate opportunistic infections. And if you look at this is data from 30 years ago. These are data where people simply look to see when did these diseases occur and what were the CD4 counts. And right now, I think we're all probably very facile with saying that CMV only occurs less than 100, PCP only occurs less than 200. But I think we just have to make sure that we're not over-interpreting these data. What this slide shows you here is that there's a range at which patients develop opportunistic infections. When we make these pronouncements that it's under 100, under 200, it's a generalization, as I'll show you in a moment. So the CD4 counts in HIV are useful, although I'm going to say to you in a moment that in other populations like transplants, they may not be as useful in assuring you this protection. But just to give you an example for the one that we have the most data on, pneumocystis, these are the data that were used in the 1980s that led to the suggestion that you should use 200 as a marker for when patients develop pneumocystis. But all these dots here are cases of pneumocystis, and you can see the x-axis goes from 0 to 500. There's some patients at 300, 400, 500 who are still developing pneumocystis. So the point of using these breakpoints is that these should suggest what's more likely or less likely, but a high CD4 count doesn't preclude one of these opportunistic infections from occurring. And when the question comes up, why did the number 200 come up? There were people like Mike Sag back there sitting down and said, well, you know, most of the cases occur to the left of that line. And then there were people who said, you know, ID docs need a round number. It can't be 220, it can't be 240, it has to be 200 or 300, or nobody will remember it. So these numbers are so arbitrary. So they're helpful, but They're not that helpful. And one of the things that, again, is probably down in the weeds too much for everybody except maybe me and Christine to discuss, is that in patients who have other immunosuppression, CD4 counts are not so reliable. I won't show you the data, but if you look at transplant populations, a lot of the pneumocystis occurs over CD4 counts of 300 or 400. The problem is it occurs so infrequently, it's not clear it's worth using prophylaxis. But the point is we're lucky, and the CD4 counts are very reliable, but they're not 100%, so just keep that in mind. So let's start with a case, and I'm going to start with a couple of easy outpatient cases, which are just based on not are there any data, but what do you do? So this is a 24-year-old woman who presents with fever, cough, and shortness of breath for 3 weeks. So this is not an acute infection like influenza or COVID. Her HIV test is positive, but you don't have a CD4 count, so you have no idea whether it's low or high. Her chest exam just has wheezes and crackles, not clear whether it's consolidated. You don't have an X-ray. You do have an O2 sat, and that's fine. A rapid test for influenza and COVID is negative. So the question is, we'll wait and see if this advances. Okay. What would you do? Would you, because this patient has 3 weeks of illness and a O2 sat of 95, send the patient to the emergency room because they have HIV, treat them empirically with a cephalosporin and a Zithro, treat them with cephalosporin and trimethoprim-sulfa in case it's pneumocystis, treat them empirically with all three, or use trimethoprim-sulfa and a Zithro. And there isn't a right answer, but I'm going to ask a couple of the panel members what they would actually do if they don't have lab values. But let's see if you vote. And Khalil got 300 people to answer, so I'm not going to speak again until 300 people answer. But I might make the panel speak. Okay, so I'm 2/3 as good as Khalil, so I'll take 200. So a lot of you said trimethoprim-sulfa and a Zithro. And again, I don't think there's a right answer, but let me start. I don't know whether I should just go down the line. And I don't know, Hyman, do you want to say what you would do in your clinic?
Yeah, these are the only options, though.
I'm sorry?
Was these the only options? Yeah, so I think in this scenario, treating empirically with Septra and Zithro would make sense. This is a 24-year-old new diagnosis. The concern would be, particularly given their age, this is more likely a recently acquired HIV infection. So I'd be less concerned, but you want to definitely get the CD4 count. Because if they did have, for advanced disease, the concern about having additional OIs, and particularly with the zithromycin, might sort of give me more pause. Of course, you'd want to get a chest X-ray, but they're not hypoxic. They're not showing, signs of hypoxia on an exam. So, they wouldn't necessarily have an indication for steroids as well for treatment of likely PCP.
Yeah. Well, I won't torture everybody, but Dr. Gulick has to leave early, so I will torture him. What would you do?
I would
Although
send
you work in a
rarefied,
high resource place, but if you didn't have all that, what would you do?
So Henry was at Cornell for years, so he can say that.
I was there when it was great.
Wow.
We aspire to be as great as that was. Thank you for that comment.
Make Cornell great again.
I would just reiterate that this has been going on for 3 weeks, which concerns me that this isn't an acute bacterial process. So I would opt for choice A and send her to the emergency room to get more data rather than treating empirically for either a bacterial infection, which seems unlikely, or pneumocystis, where you'd really like to know how sick she is.
Mm-hmm. Yeah, well, let's leave this case there because, again, a lot of this is clinical judgment, knowing the patient, knowing whether the patient will come back the next day or the day after to see if they're better. So there isn't a right answer to these, and there isn't any data, but at least you hear what two of our experts think. So let's do a little different variation. The same 24-year-old woman with long-standing HIV has fever and cough, so it's 3 weeks, but this time you know that her CD4 count is 100 and her viral load is quite high. She hasn't been adherent to her antiretroviral therapy. At this point, you examine her, she still has wheezes, you don't have a chest X-ray, and her O2 sat is 95. So again, this time you know she has a CD4 count of 100. So, going back to Jaime, would you be more likely to send this patient right to the ER since you know she has a low CD4?
Absolutely. Yeah, this is someone who I think is at high risk for having complications, potentially multiple OIs, and the duration of these symptoms. We often see 2 or more OIs diagnosed when someone presents with what looks like classic PCP, for example.
And to make sure that the whole panel stays awake, I'll just ask them randomly. Jennifer, anything you do differently?
No, this patient I would really push to go to the emergency room. I will say, as somebody who works in a place that is under-resourced and we don't even really have a lot of access to emergency rooms in our area, in some of our areas, that first case I would have treated empirically and had them return to make sure that they were, improving. But this case, I think the chance that you're catching it at the beginning and it's just going to get worse is not a small possibility. And then the possibility that she's going to get IRIS with treatment isn't terribly small with that high viral load. So I might worry about her a lot more.
Dr. Masur keeps hiding the chest X-ray from us. I don't know, it's hiding something. But I just want to say it will probably not sway me, even if it was negative.
Well, not everybody has access to a chest X-ray, but I think one of the things about pneumocystis, just keep in mind, is in a transplant population or a cancer population, I'll get to you in 1 second, in a cancer transplant population, pneumocystis is usually pretty acute in 2 days, 3 days. In HIV, it's often very subacute. So just because this is going on for 3 weeks, shouldn't dissuade you from thinking about pneumocystis. This is perfectly consistent with pneumocystis. You had a question?
It's common, actually. On Fridays, every Friday afternoon in 1989, we had at least one person with pneumocystis who came in. And excuse me, we had a respiratory therapist at the hospital who spent hundreds of dollars to buy us an oximeter, which was very exciting. People desaturate when they have pneumocystis. And if you're not sure how sick somebody is, just walk them a little bit and check their PO2 again. And if they desaturate, your decision to go to the ER is made. It's really easy.
Yeah. Well, that's a good point. And it just goes to show that older doctors are still useful.
So we used to have people go up the stairs, go up 2 flights of stairs and come down and then recheck their O2 sat. And if it drops, then that's pretty suggestive.
If the cable
Okay.
back up.
So let's move on. So we'll talk a little bit about pulmonary disease, and we'll talk about some inpatients. But I wanted to make I'll make a few comments, but let me ask you a question first. What's the most common serious cause of pulmonary disease in people with HIV? If you don't vote faster, we could talk faster. All right, so this, I guess, is a good question, although the point I'm going to make about MAC and CMV, it looks like everybody already knows. So the point is, pneumocystis, we all talk about with HIV, but keep in mind 2 things. Patients with HIV get non-opportunistic infections. Number 2, if you look at data, and admittedly, the data is not perfect. Pneumococcus and Haemophilus are very common causes of upper and lower respiratory infections. So don't always jump to opportunistic infections. But if you look at some of the big studies that were done in the 80s or 90s, bacterial causes of upper and lower tract infection were much more common than the classic opportunistic infections, although pneumococcus is opportunistic in that it causes more invasive disease. So the point is, don't jump to thinking it's an opportunistic infection, even if the CD4 count is low. think of typical and atypical causes. And also, as our patients get to be older, as they have heart disease due to other factors like cocaine, think of congestive heart failure, pulmonary emboli, neoplastic disease. So make sure you keep your differential broad, although infections are clearly an issue. One of the things about pathogens as we get into it is there's some things that are common. Pneumococcus and pneumocystis are clearly common at the right, particularly pneumocystis, the right CD4 count. And TB, depending on where you practice, maybe not in most places in the United States, but certainly abroad is very common. But one of the issues as you get good diagnostic tests is CMV in Christine's population is very important as a pulmonary pathogen. If you have HIV alone, it doesn't cause pulmonary disease. Now, somebody in the audience, or Mike Sag or Roger will say they've seen a case that's biopsy proven. Everything happens once in a while. But CMV, Mycobacterium avium, herpes simplex, and aspergillus can all be found in the sputum. The top three in particular are colonizers, but they almost never are the cause. So when you find them, you really should be looking for something else. I'd just be interested in the panel. Would you say that's true, that particularly the house staff often gets misled by a PCR or something from the sputum that has MAC or CMV? Do anybody want to make any comment or I'm hoping you'll disagree with what I say about some of these things. So, Jennifer is nodding the most vigorously. Do you want to say something?
Yeah, I think that the PCRs can be tricky. One place that we've had some challenges is the pneumocystis PCR.
All right, we'll get into biofire and PCRs. Yes, yeah, that's a problem.
But when it's these rare things that get people excited, and they want to be the person that finds it, but rarely are these things the cause.
Yeah, we'll get into PCR because sometimes technology is great, and sometimes technology is expensive but misleading. So we'll get into that. Does anybody want to say anything about, again, the things that I have there in red? Have you ever seen a case of pulmonary disease in somebody who only has HIV, not some other disease in addition? Or at least, I guess we'd all accept the fact that don't be thinking that those are the cause of pulmonary disease. Look at something else. But just as, O2 desaturation is important, it is important still to take a history and to examine the patient. And again, if the disease is relatively acute, it's more likely to be influenza or COVID or maybe a bacterial infection. If they're afebrile, anybody can have an infection and be afebrile, but think of some of the non-infectious issues. Sputum is helpful. Is it purulent? That's not probably pneumocystis. If it's scant, you're thinking of a virus or pneumocystis, so that's important to look at. If you examine your patient or do bedside or point-of-care ultrasound, if they have a lobar pneumonia, it's probably not pneumocystis. And Roger wanted an X-ray, but they're at best suggestive and not diagnostic. So let's go to another case. Your patient with pneumocystis, we don't know what the patient is. Your patient was treated with trimethoprim sulfa plus azithro for 2 days, but then was still febrile, the cough was worse, is more short of breath, and the O2 saturation is lower. We're still waiting for the CD4 count. The patient goes to the ER. The chest X-ray shows diffuse interstitial infiltrates, and again, that can be lots of different viruses, could have been bacteria, could be pneumocystis. So the question is, which of the following should be done to determine if pneumocystis is the etiology? And I would just predict that of the 6 people here, we won't agree on the answer, but we'll see. So let's see what you all think. And I'll tell you my strong prejudices, and then they can tell you the facts. All right, come on, vote faster. We're only up to 140. All right. Well, I'm glad Khalil is not here because he would complain for the next year that he got more votes than I did. So I think most of you know that a BAL is the appropriate test. That there is no serum pneumocystis PCR antibody. Beta-D glucan. Paul Sachs and I have had an amusing debate for the last 30 years. Does anybody here think that there is any reason on earth for any disease to get a beta-glucan?
Not anymore.
Tell me one reason why you would ever order that. Because it's not sensitive, it's not specific. I'll show you some data, but I don't think that should, for sepsis or anything else. But Roger, how often do you order it?
We order it because we have it. No, just kidding.
All right, well, that's good. And a CT scan, might give you some information, but it's not going to help you with the diagnosis. And again, we don't do transbronchial biopsies much anymore. So let's see. I seem to be slow on getting my slides. Oh, here we go. So, it is interesting that over the last, or it's at least interesting to me, that over the last 45 years, we've come a long way in terms of being able to make a diagnosis because of pneumocystis. Because, again, looking down the line here, probably even Tripp doesn't remember the era when we actually did open lung biopsies or transbronchial biopsies to make a diagnosis. And when we finally learned how to do bronchoalveolar lavage, and that was really accelerated by HIV, it was almost never used before that in other patients, and then do sputum, now we have a way to get a sample. So that has been an advance. On the right side, I'm not sure we have made progress because we used to use very complicated stains, and some of the older people probably remember going and looking at silver stains and seeing if there was pneumocystis. There are some other stains. Joe Kovacs in our lab developed the immunofluorescence test, another of Tripp's Cornell graduates. So the test that is usually used to look at sputum or bronchoalveolar lavage is now based on immunofluorescence. If that is positive, the patient definitely has disease due to pneumocystis and definitely should be treated. The question about PCR that Jennifer brought up is a problem. We're going to deal with this here and in the breakout session because PCR, as you know, is so sensitive that you can find the organism, but you don't know how much is there, even with cycle number, so you're never sure of whether it's the cause of the disease or not. I see we get another opinion. Let me just say two more things and we'll get to you. When you see a positive PCR, you know that pneumocystis is there, but there are healthy people and immunosuppressed patients who are colonized because, in fact, almost everybody in this room is probably seropositive because studies have shown that in the first 6 months of life, over 50% of people convert their antibody. Now, where you get the pneumocystis is a complicated story. But so there's pneumocystis around, and people do get colonized, but that doesn't mean it's the cause of the disease. Now, if somebody had this history with fever, shortness of breath, diffuse interstitial infiltrates, and a positive PCR, would I treat them for pneumocystis? Of course. But I think you can get fooled sometimes. But go ahead, you probably will come up with some more recent data.
No, I just wanted to make a comment about the use of beta-D-glucan in an HIV negative person. Yeah. That's actually where it's been helpful. I read this case in the New England Journal, I don't know, maybe a few years ago on the airplane, and they mentioned using this as kind of a hack. When you have a patient who's non-HIV and they're on methotrexate or whatever, and it could be anything, and you have a PCR that's positive in the lung, what do you do with that? But for patient in our N of 10 or whatever in Colorado, when I've checked it and it's been over 500 and you treat them with pneumocystis treatment.
Yeah, you've been reading Paul Sachs too much. No, you make a good point, I'm probably being a little bit extreme, but I think even in sepsis, the sepsis guidelines suggest that there's no utility. The new sepsis guidelines are coming out. So I'll show you some data in a moment. Let's see if I have it here.
She's right. If you use a cutoff of greater than 400, your specificity goes up to 97%, even in HIV. So there's some good data on that. And so you could save a bronchoscopy if you have access to the test, and it's greater than...
Did we call on you? I don't remember calling on you.
I'm just a colleague here.
This debate could go on for... We could have a session just on this, in which I could tell you why I disagree with her. She won't listen, so... Are you a surgeon? So anyway, so the PCR for pneumocystis, again, is not useful in the blood. If it's negative, you know the patient doesn't have pneumocystis. If it's positive, again, you don't know whether they're colonized or not. You have to use your clinical judgment. This is the issue about beta-D-glucan. And again, Christina could have shown me another series of dot plots, but this is an older study that shows patients with beta-D-glucan with pneumocystis and not pneumocystis. And you can see, clearly patients with pneumocystis are more likely to be positive. They are the ones who are over 400, all right, I'll give you that. But I don't think it's worth the time and effort to do it. But let's move on. All right, so therapy. So I think everybody knows that trimethoprim sulfa is the drug of choice. You know, there was a time, has anybody up here on the panel ever used pentamidine? All right, what do you think of pentamidine?
Toxic.
IV pentamidine.
Toxic.
Yeah, I mean, you know, but AIDS was starting just as trimethoprim sulfa was shown by Walter Hughes to be effective for pneumocystis prophylaxis. Do you have a question back there?
Yeah, I just had one last thing.
Go
Sorry to keep going back
about
to the beta-D-glucan. In our system, in many, it takes so long to get the induced sputum and the result. We do PCR. We unfortunately don't do immunofluorescence. So where it's helpful for us is if someone has a negative result because of a good negative predictive value and toxicity on high-dose trimethoprim sulfa, we can decide in that moment while we're waiting what to do. So while it doesn't give us the answer, in the management, I find it extremely helpful, particularly at adding the LDH, adding whether there was desaturation, primarily for if there's a toxicity or there's a severe allergy. So it's the pre-management, because really it takes 4 to 5 days for us to get a confirmatory result, which is a long time to be on a high-dose toxic drug.
Well, it's true, and then you have to use your clinical judgment or you're just going to treat them empirically. But anybody here want to make a comment on this? No, I mean, I think we're all sort of in the same boat. And like LDH, you know, there was a time when we used LDH thinking it was specific, and I think now we realize it's a non-specific indicator of lung damage. But, you know, all these things help decide how sick the patient is. So let's move on. But the point about pentamidine is we used to use that, and it's a very effective drug, but so toxic you probably don't want to use IV pentamidine unless you're really desperate. Atovaquone is a pretty good drug if you can absorb it, but you have to be able to take a high-fat meal. And clendropyrimiquine, I was skeptical about because you have to take the pyrimequine orally. And if you have a sick patient, oral drugs are presumably not optimal, but pyrimequine is very well absorbed, and the trials would show that it's just as good as trimethoprim sulfa, which I'm skeptical about. But steroids, I think, are something that you have to keep in mind if you're doing inpatient management, because there's a lot of controversy about using steroids for community-acquired pneumonia, which we're going to talk about in the breakout session. This data is showing that it's harmful in influenza. This data is showing that it's helpful in COVID. But pneumocystis really has the best trials, and that shows that if you are hypoxic, if you, say, have a PO2 under 70 or a high A gradient, if you add adjunctive corticosteroids to standard therapy, you will decrease the likelihood of death, or you'll increase survival. So steroids in this situation are life-saving. There's a lot of concerns whether if you gave a 21-day course of steroids, you would exacerbate CMV or mycobacterium or Kaposi. That doesn't appear to be the case. So I think this is standard of care. And I presume that, yeah, Mike, go ahead.
Yeah, so this is something I really wanted to bring up and goes back to the initial presentation. Assuming that woman who presented actually had PJP, even with a PaO2 of oxygen sat of 95%, it helps to know the original study and the details of how that study got to the criteria that you listed there of a PaO2 less than 70 and an AA gradient greater than 30. The reason that's there is that Fred Sattler in California proposed a study. It went to an IRB, and the IRB said you can't give steroids to an immunosuppressed patient. So they had to modify the inclusion criteria to the criteria that you see here. It's an artifact. It's a remnant of a IRB-induced problem. The deal is that when you give treatment doses of trim sulfa to somebody who has, sure enough, pneumocystis, they are going to have oxygen desaturation over the first 2 days if you don't get steroids, even if their original PaO2 is normal. So I would be loath to give somebody who I wasn't sure had HIV and pneumocystis Trimsulfa as an outpatient without knowing more. And for me, in my practice, and it's not in the guidelines because there aren't data other than just extrapolating from the original curve in the study you're showing here, but I've had plenty of patients who came in with normal PaO2s or close to normal, who about day 2, if they didn't get steroids, were in the ICU. And we had a study of something called trimethoxate that really is a great drug for pneumocystis, but it had higher rates of failure because we weren't using steroids, especially in people who had normal oxygen saturations at baseline. It's a much more potent drug, same class basically, but that's something I would advocate for, and I may be alone on that, but if you really look at that Bozzetti paper carefully and look at figure 4 precisely, you will see the desaturation occurring in everyone who did not get steroids at the beginning.
Yeah, I think that's a good point, because I think if you look at that data, and I'm impressed that Mike remembers which figure it was. I'm going to look up to see if that's true. But if you give people with mild pneumocystis corticosteroids, they will get less ill and return to normal respiratory health faster. The reason it was never approved, just to expand on what Mike said, is you have to do a study which shows a significant endpoint like death or time in the ICU or the time in the hospital. If you have mild disease, it's hard to find that endpoint. But if you look at the physiology in some of the small studies that were very granular, it clearly makes people feel better faster, and or it also prevents deterioration, so they feel better faster. And again, there don't appear to be any downsides to 21 days. So I don't know, does anybody on the panel disagree with where we're going on this? But I still wouldn't give it unless somebody was severely hypoxic. But I wouldn't worry too much whether they're 70 or 75 or 80. If you think they're going downhill or their saturation is below what you're comfortable, I would personally give it. But the guidelines are very specific because they're evidence-based. But you have to decide based on the guidelines. They are not rules that you must follow. You have to interpret them.
Also, in the follow-up that you showed of that case, she got treated with Trimsulfa. She comes back a few days later, and her PaO2 is dropped. And I would argue that Trimsulfa had something to do with that, assuming she had pneumocystis.
Well, that's a good point.
I was also about to say that it wasn't a thing back then, but iris may have something to do with this curve.
Okay, yeah, we'll get into iris in a moment, and I realize that I haven't called on Sandy yet, so she can think that she'll probably be next.
Oh.
Okay, do you want to say something now?
I wanted to comment too, in a 24-year-old, 95% O2 sat, just at baseline, would make me worried, but I was going to say I was going to walk her too. But the other, to see if she desatted, but the other comment I wanted to make is, why is she non-adherent to her antiretroviral therapy as a 24-year-old? So there's other things going on, and I wouldn't have sent her home if she, if there's ongoing substance use and was unhoused or other things that were leading to her. So anyways, I just want to comment on that, and yes.
Well, that's a good point. That she's not adherent, you may never see her again.
Yeah.
That's a good point. So here is somebody who is a little bit different. This is somebody who is, again, a woman with HIV positive CD4 of 103. She's intubated, started on trimethoprim and prednisone. On day 4, let's see what happened. You think, should she start antiretroviral therapy? Now, she's 4 days into this. She's intubated, so she's sick. So this isn't an easy case of somebody has herpes zoster, when should you start it? This is somebody who's sick, and I don't think the guidelines are going to be helpful. I think you need some clinical judgment. So how do you vote here? Would you start antiretroviral therapy right away because she needs better immune response? Would you start in the next 2 weeks? Would you complete 21 days of trimethoprim or wait till she's hopefully discharged? All right, I'm stuck at 200. All right, so most people here would start immediately. And again, there isn't a right or wrong case. Who would like to tackle this first? Roger, you're looking like you would.
I think she's not getting worse, she's just not getting better. And I think that it's important to realize that suppressing her viremia may have a lot to do with the future outcome. So I would start the treatment immediately. Unfortunately, this is also one of those instances where we're not really likely to get better data than the one that we had very long time ago. We have very scant information on the timing of antiretroviral therapy with acute OI, save TB, crypto, and other things. But
yeah, I'm going to ask a couple of other people, but I would suspect if you ask different people, you'll get different answers because one of the things I would worry about with many OIs is that you get an iris, an immune reconstitution syndrome. We'll talk about that in a minute. The issue though with pneumocystis is it happens, it doesn't happen very often. Now we could have a case of toxo where it almost never happens to cerebral toxo, but it can happen. So the question is, you're dealing with the consideration of iris or this post-therapy pneumocystis response, which is, I guess, another cause for more inflammation. So, I don't know, Mike, you're looking perplexed. What would you do?
No, I would definitely start right away. In this study, Zalopa et al. Back in the 90s showed that more immediate therapy in this state is really helpful. Secondly, you got her covered.
You can show them this slide.
Yeah, there it is. So
what figure was that?
The take-home point is that you've already got her covered with steroids. So iris isn't going to come up at least while she's in the ICU on steroids. So give her immune system a break, get the virus out of the way. We talked over the last 2 days about how the virus is really the culprit causing the immune suppression. Take care of it now, help her recover more rapidly.
Yeah, well, I mean, that's a good point because, in the guidelines, and again, the guidelines are just one way of looking at it. There's even a discussion of when would you use prophylactic steroids, and the specific section is on TB, but this patient's on steroids, so you're sort of preventing an iris, so that's positive, but who else wants to say something?
Yeah, I think also say that this study is one, just like the one you showed earlier from Bozzetti, where it's important to know the genesis. This was not the primary endpoint, survival without an OI, but it did not meet it. And there were very few OIs in this case, if you stratify by the types of OI. But that is the best data we have, which is not a whole lot and which is very old.
And this was not an ICU population largely. These were mostly pneumocystis. So the general rule of starting antiretrovirals within 2 weeks doesn't really tell you whether to start it on day 1 or day 13. And again, this is a general guideline. So I presume that we'll get into TB and fungi in a moment, but I presume this is generally what you try to do with most patients, to start antiretrovirals sooner rather than later. Sandy, do you want to make any comment about that?
Yeah, no, I mean, I was thinking the same way. The only thing, worrying about her, she's in the ICU, she's intubated, just being aware of which antiretrovirals, and also she's may or may not be aware that you're starting antiretrovirals on her too. I don't know if she's awake.
Well, and you worry about drug-drug interactions, all the other things the
but
intensivist has started.
But that doesn't mean that I'm not a fan of starting early. I still would.
All right. Well, the point is just it's more complicated than it seems, and obviously it's great if you look up the guidelines and say start within 2 weeks, but that doesn't fix the nuance of every patient. All right, so let's go to another disease. And again, we worry, I'll show you a table about all the different manifestations of virus in a little while, but we worry mostly about endemic fungi, histo, crypto, cocci, and TB. So, as far as TB is concerned, so another 50-year-old woman out of medical care with 3 months of cough and fever, so this is 3 months, not 3 weeks, is admitted to the hospital through the ER and is diagnosed with pulmonary tuberculosis and started on, traditional RIPE regimen. So she's not on antiretrovirals at that point. There's no clinical evidence of extrapulmonary TB, but of course you don't know whether the subclinical disease in her meninges or pericardium or other place. She's HIV positive and has a low viral load, a low CD4 count and a high viral load. So the question is, when would you start antiretrovirals in this patient? I think it's the people in the back room who are not voting. Okay, 200. All right. So 36% of you would start immediately. Okay? I mean, it depends on the CD4 count. It depends on what her disease is. But what do we do in clinic? Does anybody want to volunteer? Who sees the most TB around here?
Do you see left?
Florida must have TB.
We have a lot of TB, and
All right,
we
so what do
actually
you
have
do?
3 active cases in my little rural clinics. We do the 2 to 8 weeks after starting right. We've had a lot of people with disseminated TB that wasn't initially recognized. You know, it was there was a concern, but so we're doing 2 to 8 weeks after starting right, just because of the risk of you can get immune reconstitute from TB therapy by itself, and you can immune reconstitute with the HIV medications. So
well, that's a good point, because I mean, certainly pneumocystis TB, I think, was the original disease where the terminology keeps changing, called paradoxical reaction. You treat them, they get worse, and at least I never understood why that was. Now, I guess, you know, the theory is you're releasing evil antigens, that's causing more inflammation, therefore you get more hypoxic. I don't know whether that's true or not. But yes, that certainly happens. And again, you're not probably going to CT the patient and do an LP and so on, find out what they have in this case. But she's certainly at risk for iris because she has a low CD4 and a high viral load. But Roger, what would you do?
No, just like her, the concern, of course, has always been iris, and the data that got us, I guess, to 2 to 8 weeks, the Southeast Asia, where they looked at, you know, different outcomes, including iris. Iris is going to be more common in CD4 count less than 50, but on the balance, I think starting RIPE at a couple of weeks is probably the best option.
Sandy?
I agree.
Okay. Well, again, you know, there are many nuances to these issues. And does anybody want to say anything when you start antiretrovirals? Have you had personal experience with pulmonary TB that turned out not to be just pulmonary TB? Do you want to just give a few anecdotes? And actually, if you have questions, please come up, because one of the things we try to do each year is Donna Jacobson does a great job of setting up the rules, and we're supposed to take questions afterwards. We like to break the rules. So come up and ask questions as we go along. Unless you want to talk about beta-glucan, please don't come up.
I was about to say I would send for a beta-glucan, but no, but I agree with Jennifer. There are a couple of issues. Number one is it's more likely in this person to have extrapulmonary TB than someone without HIV and such an advanced immunosuppression. The second thing is it's very possible to be happily living with 2 OIs, 2 pulmonary OIs. So it's possible that they may have a PJP as well. So it's always important to stay on the alert. Yeah, if you have diagnosed 1 OI in a person with CD4 count less than 50, you're probably not done yet.
Well, I mean, that's always important. As the patient gets worse, maybe due to the paradoxical worsening that you get, sometimes it's not completely blended with steroids. The question is, should you just stay the course? Should you do more diagnostic tests? Are they failing their trimethoprim-sulfa? That's too complicated to get into right now. We could get into it in one of the breakout sessions, but that's something you always are nervous about. If they have a dip, you're always holding your breath for 3 or 4 days to see if they start getting better. But the guidelines would say if the CD4 count is less than 50, start within 2 weeks. That means 1 to 14 days. And if the guideline is higher, you can wait longer. Do you want to explain, Mike, why there's that discrepancy? And this patient had 100, and the question is, are you more worried to treat them like less than 50? But why is there this difference between less than 50 and more than 50?
There was a study by Jerry Friedland and colleagues several years ago that had these striations, and the mortality was better in those with lower CD4 count that started their ARV therapy early. And conversely, those who started early and had higher CD4 counts didn't do quite as well. It was one of the more convoluted studies I think I'd ever seen, but those are the data. And so that's where these guidelines come from.
Yeah, I think we're also getting more comfortable with treating iris than we probably were a while ago. And one of the issues that I think we have to recognize is that the opportunistic infection studies that we rely on the most were done in the 80s and 90s before we had our current antiretroviral regimen. So we're serving different patients. A lot of the data about iris and cryptococcal meningitis and so on that we're going to talk about were not done in the United States. So there was a different intensity of managing patients. They weren't always on the same antiretrovirals. So you have to do a lot of extrapolation because there is not hard data. Anybody else want to comment on less than 50, greater than 50? Do you use this in your clinic, or how do you decide when to start? Does anybody want to make a comment?
Well, as part of trying to prevent other OIs from happening while you're waiting for them to recover, so if the CD4 count's less than 50, I do try to get that antiretroviral therapy started, within 2 weeks.
And that's presumably a lot of the reason to start, so you don't wind up with a second problem. Okay. So the question is treating immune reconstitution. I'll show you some pictures later. Immune reconstitution immune reconstitution has a lot of different flavors. It can be mild, it can be severe, and I'll show you some pictures of some of the severe adenopathy, the obstruction of various organs. But the question is then, how do you decide when to treat, and do you use prednisone like this for 4 weeks? Again, it's hard to be hard and fast, but anybody want to volunteer to start about how they deal with iris with either non-steroidals and then with steroids?
Well, I usually use steroids because they've got an issue and you're concerned about that. There is one exception that I'm aware of where steroids actually makes things a lot worse, and that's with treatment of capices. So that's one where people can flare dramatically when you give them steroids. So to your point...
Well, let me say, is that true if you give them 2 weeks or 4 weeks, you think they'll flare in that period of time?
At least that's the studies, that's been my experience working out of sub-Saharan Africa. Okay. But it does get to your point that sometimes people have pulmonary TB and pulmonary capices, and then you're really in a conundrum at that point. But that's an uncommon scenario, but it is something to think about with somebody with a very low CD4 count. Often, Occam's razor doesn't apply. You can have multiple pathogens at the same time, and KS would be a pathogen in this setting.
Yeah, well, that's a good question, a good issue, because the patients that we see with pulmonary capices usually have fairly extensive disease, and they are very difficult to treat. I don't think we have a good survival with them. But before we move on to another OI, any comments about TB? No? Okay. And I said before that it says in the guidelines that you use prophylaxis, that you can use prophylaxis. Mike made the point about capillary sarcoma or hepatitis B, but I don't know, do any of you use, I guess I asked you before, so nobody really uses prednisone prophylaxis with TB and iris? You wait for it to happen? Okay. All right, here's a different flavor of this. And this is Dr. Sagg's favorite disease, one of them. 50-year-old woman with 3 weeks of headache and fever is admitted to the hospital through the ER, diagnosed with cryptococcal meningitis. I guess I didn't say HIV. Her HIV tested positive. And she started on liposomal amphotericin and 5-FC. She has a low CD4, high viral load. So first of all, there was an intriguing study in the New England Journal about not using 2 weeks of liposomal amphotericin, but using a single dose followed by oral therapy. Has anybody done that in the United States?
No.
No.
I mean,
Okay.
the reason this was done is because it was in sub-Saharan Africa, and getting 2 weeks worth of Ampho-B in was extraordinarily difficult. So it's not a whole lot different than starting with fluconazole at higher dose. So I think in the U.S. I would still use amphotericin with 5-FC in a standard way for 2 weeks.
Yeah, so I'll show you that regimen in a second, but I think the point is, when something is published in a prominent journal, it is easier to read the abstract and decide that's what I should do. But of course, reading the details are also important. And this was a very intriguing study about using a single dose of a high-dose liposomal amphotericin, 10 milligrams, so twice as much, and then following it with oral flucytosine plus fluconazole. And actually, the results weren't bad, but the comparison was not liposomal amphotericin. It was amphotericin deoxycholate followed by fluconazole. They did use flucytosine. So the point is, it was done with a different standard of care where they probably were not able to follow intracranial pressure so carefully. The comparator was not our standard of care. So it was interesting, but I don't think it should change our
One other thing, back in the day, Bob Larson at Southern Cal did a lot of what we called flu studies with high-dose fluconazole flucytosine. It sort of worked, but there was an enormous amount of nausea and GI intolerance that made it hard. And I forget what that study showed, but 1,200 milligrams a day of fluconazole is a lot of fluconazole, and it's very hurlogenic, if you know what that term means.
Yeah, I'll show you what's the recommended regimen in a moment. So here's the question again for the panel. And let's see, I'll probably pick on the people I haven't picked on as much, so Sandy can start with this. But when should you start antiretroviral in this patient? Yeah, immediately and within 2 weeks, 48 weeks after antifungal therapy, or when the CSF cryptanogen is negative? Okay, come on, the people in the back, you got to vote.
Oh, we have somebody at the mic too.
Next week. What do you think?
Next.
Okay, 200. So again, I'm not sure there's one correct answer. So most of you would wait for 4 to 8 weeks after antifungal therapy. But Sandy, what would you do?
Yeah, no, I think there is, well, Mike has probably more comments about this, but probably in the next 2 weeks, although I can see waiting 4 to 8 weeks. Her CD4 count was it at 53? Is that right? Yeah.
All right, well, I mean,
so that's one of the concerns, and then iris developing also, so that would be a concern I would have.
Yeah, and just to say the obvious, I mean, when you're dealing with a closed space, either pericardium or the head, increased pressure is a real problem. But Mike, you've been studying this disease.
Yeah, so this
for a long
is
time.
one that I feel pretty strongly about. There's a study out of, again, sub-Saharan Africa that showed that starting earlier in the first 2 weeks or so was associated with a higher mortality than waiting 4 weeks or longer. When you look at the details of that study, the mortality overall in that study is at least twice that we ever see in the United States, Europe, Canada, or Australia. You say, well, why is that? And the answer is totally unclear, but it probably has to do with daily management of the patient in-house while they're in the hospital, managing ICP. Although they did that in the study, it wasn't enough. But when you see that type of outcome, yeah, there's an answer, but the details matter. So when I saw that study, I got together with some folks at something called the RWWC, and I said, well, I'm treating within the first 2 weeks usually, so we have data, and I can't remember the last person I've taken care of with crypto who died. I mean, it's an uncommon phenomenon. It happens, but I hadn't seen it in a long time, and I'm treating early. So we did a study, about 200 individuals, And the statisticians in some magical way mimicked a randomized trial. I don't know how the marginal structural models, God knows, I can wave hands. But the point is, in that analysis, which was in CID a couple years ago, actually the early group had less mortality than the late group. Does that mean you should do that necessarily? Not for sure, but I would not wait for 4 weeks, and you can manage the pressure, and you can start the therapy while they're leaving the hospital, or I sometimes start even earlier. I know it's heretical, and the guy who ran that study out of Minnesota wants to shoot me every time he hears me say that, but if we're going to be straightforward about what the data are and what they showed, that type of mortality that they had in that study has not been seen in the United States since 1990.
Yeah, although I must say, Mike, you know, I mean, your group knows a lot about fungal disease for a long time. I presume you would agree that cryptococcal meningitis still has a lot of morbidity if you're not an expert at managing it. So, you know, the increase in recurring pressure and the other intracerebral complications are not trivial if you're not aggressive about how to do this.
And just quickly for a fun sidebar, the reason we learned about the ICP was a study that we ran in 1990 comparing fluconazole to amphotericin B. It's basically the guidelines you see now. And the endpoint, since we didn't have enough for mortality, we looked at clearance of culture, which meant that we were tapping folks every 3 days. Well, that had an unanticipated effect of lowering mortality because we were managing ICP inadvertently. So there you go.
Yeah. So again, we encourage anybody who, there's somebody. Yeah, go ahead.
Sorry, just going back to the question about whether anybody's used the one-dose, high-dose liposomal amphotericin in the U.S. We did do it when I was in fellowship one time in one particular scenario in which the patient was not going to stay in the hospital. Let's put it that way. There was absolutely no way we were going to be able to do 2 weeks of liposomal amphotericin. We were not going to be able to arrange for outpatient amphotericin, and so in that particular scenario with shared decision-making with the patient, we did opt to do this because it's certainly better than just putting them on oral fluconazole. So just a comment there.
Yeah, well, I think, again, that gets back to the practice of medicine, and we can make these guidelines, but you have to deal with a lot of implementation issues, so I don't think anybody would take issue with that. So we've sort of gone over these issues of when to start antiretrovirals, so let's go to another case of Iris. So here's a 45-year-old woman with HIV who again has a low CD4 and a high viral load, has fever, diarrhea, and weight loss. She started on a conventional regimen. Then she develops large submental and posterior cervical lymph nodes. The biopsy shows necrotizing granulomas and acid-fast organisms, which are not TB, but which are Mycobacterium avium. So we get to the same question. Do you start antiretrovirals now? Do you start antiretrovirals and therapy for MAC? Do you start or continue antiretrovirals and start steroids? Do you stop antiretrovirals, or do you stop antiretrovirals and initiate MAC therapy? Okay, up to 200. Oops. Went back. So most of you want to initiate therapy for MAC. So let me make one comment and then see what the panel says. I suspect that because the organism is there, most of us would have trepidation about not starting MAC therapy. Whether or not you need to start MAC therapy, if you think your viral load is going to go down, your CD4 counts will go up, I don't think it's ever been shown. And I know anecdotally some people have done it and gotten away with it, but what do you all do? Does somebody want to volunteer? Would you start anti-MAC therapy and antiretroviral therapy?
Yeah, I would. I would call this unmasking MAC with antiretroviral therapy, and this all depends on the context that person is in. If they were in TB endemic area, that would almost certainly be TB, but with that lymphadenitis that grows MAC, it's akin to disseminated MAC. And I know it's not as bad as what the case down there with fever, sweat, so it's less stringent, but still should be classified as such.
And I think particularly since the regimen is generally azithromycin and ethambutol, it actually is, assuming the patient will take oral drugs, is not that complicated to start a regimen. So I think most people would be reluctant to avoid treating it, whether or not you need to do that. But it depends how sick the patient are. Again, we've talked before about whether or not to use corticosteroids. It depends how severe the lymphadenopathy is. So just a couple of words about Mycobacterium avium. It's interesting that in the 1980s, we saw a lot of disseminated MAC, and for reasons that at least are not clear to me, we don't see that much anymore. Part of it may be that people are not living with low CD4s for as long as they did before. But this organism, just to remind you, is not like TB. This is not spread person to person. This is everywhere in the environment, in the air, in dust, in your potted plants at home. So you get this by inhalation, and yet if you're immunologically normal, you almost never get this disease, you never get Mycobacterium avium disease unless you have structural lung disease. And that's another issue. So in the 80s and 90s, in patients with low CD4s, it wasn't that common to see fever, sweats, wasting. There wasn't pulmonary disease, but there were a variety of clues. But we just don't see that much of it anymore. Has anybody on the panel seen a case of disseminated MAC in the last year or two?
We see it a lot in Florida.
Do you? Okay, well, that's Florida. It's hot.
It's a
We're close to Florida.
Well, tell us what you're seeing. What manifestations? Are you seeing wasting and fever?
We see disseminated MAC. We see hepatosplenic MAC. I have a patient that we think has MAC abscesses in his arms from injection drug use that have been really a big problem. But Florida's got a ton of atypical mycobacteria, so we just see a lot of it.
Yeah, and it's almost always in the folks who were not diagnosed previously, late to care, low CD4 count, million copies of virus, and it's like the old days. It's a throwback case is what I'd call it.
Okay. So again, it's chlorithro or zithro. Zithro is easier. And ethambutol, you have to be aware of the drug interactions since particularly chlorithro is a CYP3A drug. And again, if you start finding MAC first, you start antiretrovirals as soon as you can. All right, just to show you some pictures of iris, I mean, it's seeing a subclavicular node, you may see, but this is somebody who had a very inflamed and prominent one, and the question is whether or not they're impinging on any structures like the subclavian vein or somewhere in the neck. This is somebody, just to show you, pre-artis on the left, where you can see adenopathy, which is pretty significant, but on the right you see the necrotic areas where the nodes are bigger and necrotic. So again, these can be pretty dramatic. And if you look at immune reconstitution, anything you can imagine that would appear clinically when an organism, when there's an organism present and there's inflammation, you can see a manifestation. So if it's unrecognized cryptococcus in the meninges, you'll get the onset of meningitis or worsening meningitis. Pneumocystis isn't that common, but there are cases where there have been exacerbations when you start antiretroviral therapy, even weeks after you start trimethoprim sulfa. With CMV, it has been common, at least in the past, to see either the onset or exacerbation of retinitis and so on. So you can see almost any organism exacerbated, or they have what I'm sure you all recognize is the new onset of pathogens, where suddenly you see somebody who is unmasked because they have VZV or they have PML that you weren't aware of.
Henry, let me modify a couple, go back if you don't mind. So the comment I made about capices was in the setting of iris. Sorry, I should have mentioned that. That's where actually the iris reaction to capices can be exacerbated when using steroids. Other things about crypto, that following the antigen in the CSF, it will never clear. So forget about that. And so it'll drop. Serum antigen never, usually doesn't respond to therapy, so it's going to stay elevated.
All right, I think this is our last case. A patient was recently found to be HIV positive. Again, low CD4, high viral load, no therapy. He knows the lesions that you see here on his trunk, and he otherwise felt fine. So one of the questions is, looking at this, can you be confident this is Kaposi sarcoma? So the question was, if this isn't Kaposi sarcoma, what's the most classic organism that can masquerade as this? Because again, you don't want to start therapy for Kaposi's or neglect to treat something that's treatable. So is it Cryptococcus, Blastomyces, T. pallidum, M. genevense, Bartonella henselae? These are a lot of names that are meant just to confuse and intimidate you. Some of these, like Blastomyces, I think on any exam, that's always the wrong answer. And probably the same as Mycobacterium genevense. Well, you're slowing down, which I guess is okay because we only have 5 minutes left. We're getting close to 200. All right, we're there. All right, so the point, I'll give everybody partial credit for saying syphilis because we all know that can do anything. But I think the point is Bartonella henselae can cause these cutaneous lesions. I'm always impressed that when Jane Kaler, who at UCSF, who's sort of the world's expert, she says she can't tell the difference between Bartonella and KS. So if she can't tell the difference, then I expect none of the rest of us can. So the question is whether or not you do a biopsy. Does anybody here want to say, do you do a biopsy? Do you make a clinical diagnosis? What do you do?
Yeah, every time.
Biopsy.
So you want to diagnose it, but I will say that the cases of Bartonella usually have high fever. That's kind of a hallmark. The other thing is, we don't use a physical exam much anymore, but one thing you really should do, anybody who has skin lesions of Kaposi's, look in their mouth. If they have oral lesions, that implies they have internal Kaposi's somewhere in their GI tract or lungs. So, and that would be an indication for chemo. So that's a critical thing.
He's taking all my slides away. Go ahead.
Oh, sorry.
Go ahead.
That's it.
No, that's good.
Yeah.
Other comments? So let me just say a couple things about HHV-8. And I'm trying to think if the panel will disagree with me. But I think unless you're dealing with Castleman disease or primary fusion cell lymphoma, there's almost never a reason to get an HHV-8 PCR or antibody. It's not going to help you. And it doesn't help you with this diagnosis because almost everybody with HIV-related KS will be HHV positive. And the height of the titer really doesn't help you. The diagnosis is based on pathology. And at some other venue, if you're really interested in the complexities of managing Castleman's disease or primary fusion cell lymphoma, maybe there's an indication there. But there's really no reason to think about getting diagnostic tests on blood for HHV-8. So here's another question, then we'll say something else about the pathology. The patient pictured in the last case has 24 skin lesions. The HIV diagnosis is new and they just started antiretroviral, otherwise asymptomatic, and after listening to Dr. Sag, the doctor looked at the mucosa and there was nothing in the mucosa. The chest x-ray is normal, the routine labs are normal, and a punch biopsy reveals KS. So how would you manage this in your clinic? So this isn't a right or wrong answer, but the question is, what would you do? Refer the patient to an oncologist, continue to manage in the clinic, but obtain a CT, obtain an HHV-8 level, and again, if you say that, please come up and see me afterwards. Follow prospectively on antiretroviral therapy with no other diagnostic or therapeutic issues, or in your clinic, yourself add liposomal doxorubicin.
You get a beta-2 glucan here?
Huh?
Beta-2 glucan? No.
this is going to be perfect. We're just going to be done this just on time. If you people would vote faster. All right, I guess I'm just not Khalil Ghanem, 200. Okay. Okay, so again, referring him to an oncologist is fine. What would you all do? Would you be willing to just follow the patient for 6 months and see what happens with skin lesions, Roger?
Yeah, like Dr. Sachs said, the first thing is to make sure they don't have visceral KS, which would change the...
They don't have what?
Visceral KS,
okay.
Which would change things. So if I have a low threshold of ordering order.
So would you do CTs to see, or would you just assume that if you see the skin lesions otherwise fine, you could just go ahead?
I look in the mouth. No, just, yeah, but if there's any, especially if there's any clinical indications, I'll do imaging. It's important to rule out visceral KS. If it's not the case, I'll be happy with B answer.
Yeah. Anybody else want to say, what do you actually do in your clinic?
Yeah, no, oh, go ahead.
Go ahead, Sandy.
No, I was going to say I would be worried, just like Mike and Roger just said, in obtaining the scans and also, but just doing a good physical exam, looking inside, but I would be really concerned if I saw a liver lesion or other lesions at high risk, so.
Yeah.
But I'd also talk to oncology.
And just the last thing in our last 15, do any of you actually give chemotherapy yourselves rather than sending them to an oncologist?
No.
No, okay. So, I mean, again, there's doxorubicin, paclitaxel, pomalidomide, but I think most of us don't have experience with that. So anyway, I think hopefully this was a useful review. I think, again, I'm very impressed with Heather and Brett, what HRSA does and doesn't get nearly enough. Maybe it's good that you don't get enough attention in the press, but it's really remarkable how much progress we've made. I'm glad that you're having less and less experience with these diseases, and thanks to the panel for putting up with being put on the spot.
Thank you, Henry.